Welcome. Thanks for joining us. This is the first episode in the Healthcare 2022 series. What is past is prologue. In the first days of November 2020, I posted the final episode of a 5-part series entitled Healthcare 2020. It was just days before the presidential election. In one of those episodes in that series, I interviewed healthcare economist Ron Howrigan to discuss each presidential candidate's healthcare platform, or lack thereof, and the likely impact their plan would have on patients, doctors, hospitals, insurance companies, and the U.S. economy. In that interview, we discussed the 5 pillars of Joe Biden's healthcare platform. One of those pillars was to end surprise medical bills. A surprise medical bill happens when a patient with health insurance unknowingly receives medical care from a provider or a facility outside their health plan's network. Surprise! Afterwards, they receive a ginormously large medical bill. A ridiculously high medical bill for the services they receive from the non-contracted provider or facility. The feeling of the patient who receives an absurdly high medical bill from an out-of-network provider or facility ostensibly results in a feeling of surprise. Surprise! More likely, they feel a whole host of other very negative emotions as well. Anyway, the health insurance company won't pay the ginormously large medical bill because the facility or the provider were out of network, leaving the patient responsible for a mind-numbing medical bill for the services they assumed were covered by their health insurance plan. Surprise medical bills can occur in both emergency and non-emergency care. Anyway, after we finished the interview, Ron shared with me offline his personal experience with the surprise medical bill that he had received just a few months earlier. I asked him if he was willing to discuss it on the show, and he was. So I set up an interview with Ron a couple of weeks later, still before the presidential election. After hearing Ron's personal experience with surprise medical bills, I more fully understood how complicated the issue was, and the intractable disagreement between the health insurance industry and the out-of-network providers on what constitutes a reasonable payment for services rendered to the patient. What's reasonable to one person may not be reasonable to the other. With Ron having vast experience on both sides of the health insurance industry for 30 years, he was in a unique position to see all sides of this issue. Anyway, the interview occurred at the end of October 2020 and was supposed to be published in late December, after the election and the holidays. Unfortunately, by the middle of November, heading into Thanksgiving, we were entering COVID hell in Southern California. And by the week after Thanksgiving, COVID-19 patients had taken over most hospitals in Southern California. 1 week later, I became ill with COVID-19 myself. Surprise! And I wasn't able to produce a new show for months. Finally, as we are slowly exiting the COVID-19 pandemic and entering a more chronic phase of our dystopian future, it's time to take a close look at some of the wildly dysfunctional aspects of our broken healthcare and economic system. This first episode in the series is appropriately titled, What's Past is Prologue, and begin this series exactly where we left off in November 2020. No, I haven't abandoned the COVID-19 pandemic and the vaccine mandate and its ongoing effects. There's still a lot more to talk about on that front. But we can walk and chew bubblegum at the same time. Welcome. I'm Frank Sweeney, and this is Straight Talk MD.
It is a system which has conscripted vast human and material resources into the building of a tightly knit, highly efficient machine that combines military, diplomatic, intelligence, economic, scientific, and political operations.
Once upon a time, I was young and naive, and I had a toothache. Instead of going to the expert, the dentist, I thought I could handle it myself. No problem. I got this. So I tied one end of a piece of string around my painful tooth and the other end to a doorknob to extract it myself. Some things are better left to the experts. A perfect example is your website. Brunch is the expert when it comes to building websites and managing your online presence. Visit them at buybrunch.com to schedule your consultation today. That's BUYbrunch.com. Buybrunch.com. I have healthcare economist Ron Hourigan in the virtual studio to help break it down for us. Ron is the president and founder of Fulcrum Strategies and the author of Flatlining: How Healthcare Could Kill the U.S. Economy. Before he created Fulcrum Strategies, Ron worked for 3 of the largest U.S. healthcare insurance companies. With 31 years of experience in the healthcare industry on both sides of the equation, Ron understands this healthcare system better than anyone. There was a lot of chatter on the pillars of the Biden healthcare reform platform after your last show. So I spoke with you and we decided to set this show up because people wanted to know. We've had a show on surprise billing before, but it was at a little different level. This is the federal level. Last time it was at the California level, and that law did pass, and we'll talk about that later. But when we had our discussion after the last show, you mentioned to me that you had just had a surgery not too long ago in the beginning of August, and you had received a bill. And actually, ironically, you are the victim of surprise billing, if you want to call it being a victim.
Yep.
So let's go through that, your experience. So first, when you saw that bill, what was the first thing that you thought of? I mean, when you looked at the bill, were you prepared for that or not really?
Well, I was prepared for it because I work in the industry and I know how these things work and what this looks like. My first thought was, if I weren't in this industry, this would be a complete surprise and shock to me. And for most people, a really difficult bill to swallow. You know, I felt really sorry for people who don't understand this and don't know how to deal with it.
So tell us what led up to your surgery. You had a surgery, just so people understand the context.
I had a torn meniscus. What led up to it, I wish there was a better story, but I was walking upstairs and felt a sharp pain in my knee and then significant pain and difficulty moving, etc. after that. So I went to see an orthopedic surgeon and he did what they do and did an x-ray and an MRI and said, yeah, you've got a torn meniscus in your right knee. We need to get you into surgery. Let's get you scheduled so that we can get this done and get you out of pain as quickly as possible.
So how did you get to the orthopedic surgeon? I mean, so your knee was in pain. Did you go straight to the orthopod? Or?
Yeah, I didn't go through my primary care physician. I went straight to the orthopod, scheduled an appointment for him to evaluate what was going on with my knee.
When you decided you were going to have surgery, when he told you were going to have surgery, did you need to get pre-authorization from your health plan?
I did not. There was no prior authorization. He could schedule the surgery at an ambulatory surgery center. I think it was about 2 weeks after my MRI that he could get me in on one of his surgery days.
Did it factor in when you picked that surgeon that he was an in-network surgeon? Or I should ask you first, is he an in-network provider for your health plan?
Yes. Yeah, he's in-network. That factored into it, absolutely. I picked an in-network surgeon. The ambulatory surgery center is in-network. Those were factors, obviously, in my decision.
Okay, so he schedules you for surgery, 2 weeks later? So, you after he got the result and he said, hey, you need surgery, he said 2 weeks from now you're going to have your surgery, correct?
Exactly.
How did you pick your anesthesiologist?
Well, and here's where it gets to the point where if it was somebody not so deeply in the industry, how this could be so surprising. Because, you don't pick your anesthesiologist. There's one group that covers that surgery center. Now, I knew this because I'm in the industry. That group happens to be the same group that covers both of the hospitals in my city. And really, every possible place for my surgeon to do this surgery, it would have been the same anesthesia group. And I knew, only because I'm in the industry, that they had been terminated by my insurance carrier several months earlier, so they were out of network. Now, I, just because I know and understand all this stuff, said, well, let me figure out where else I could go, how long it would take to get this done, what are my other options? So for me, the only way to find an in-network anesthesiologist would be to go to one of the two university systems in my area, the University of North Carolina or Duke University Medical Center. Now, I would have had to start all over with a new evaluation with an orthopod. Their wait times for a new patient were several weeks, more likely more than a month before I could get in. And then they would have to schedule me for their surgery in their surgery center or hospital, which would have been another several weeks. So if I had decided, and only because I know the industry, to get to a place where there was both an in-network surgeon and an in-network anesthesiologist, it would have delayed my surgery probably 2 months. And I would have had a whole different surgeon that I don't have a relationship with. This surgeon that I chose had done surgery on my shoulder a couple years ago. So I chose not to pursue that and go ahead and have the surgery done with him, with this out-of-network anesthesiologist. But nobody else would have known to even do that. They would have been completely surprised by, wow, I didn't know this. There was going to be this other doctor working on me that wasn't in network, and I'm going to get a bill from him.
Exactly. So you were not informed. I mean, you're an insider, so it's like me. I tend to know things like that a normal patient would not know.
Right.
So there was no notification, hey, by the way, there will be an out-of-network provider before you showed up on game day.
No, there was no notification of that, nor was one required in my state. They weren't doing anything wrong. They don't have to.
Right. Okay. So did anyone tell you in advance what the estimated cost would be for each provider?
Well, actually, the orthopedic surgeon did. As part of their scheduling the surgery, they looked up my benefits and said, it looks like you'll have to pay about X dollars. And it was very reasonable because they were in network. I've already met my deductible, et cetera. So they did. And that was great that they did that. And it wasn't that much money for me to get it done through them. But nobody from the anesthesia group did that, told me what they thought the estimate would be.
How about the facility fee?
The facility called as well.
And they gave you an estimate?
Yep.
Okay,
Yep.
Good. Okay, great. So I mean, that to me, that's impressive.
It is. It's very impressive.
If and I mean roughly, how long did the surgery take? Roughly, how long do you think it took?
I think the surgeon said that from sort of start to finish was going to be a little bit less than an hour.
Okay, that's pretty typical. Anything special that happened in surgery? Did you get some special treatment, like any gold-plated knee brace or anything like that?
I would like to say, since I know the surgeon and I'm in the industry, I got some special treatment, but I didn't. I got the exact treatment every other patient did.
From what I gathered, the date of service and from your EOB was August 13th. So it's been a while. How did the recovery go after surgery? Pretty good?
Recoveries went pretty well. I mean, it's exactly what he described. It'll be sore for a while and slowly get better and return to normal activity. But the surgery was a success. Everything's been good, and recovery's been fine.
Okay, so to the point of you were kind enough, and I really appreciate it because this really gives insight to me. I'm an anesthesiologist, and I get to see the bill you got from an anesthesiologist, or should I say two anesthesiologists, which raises another question. But when I saw your bill for your knee arthroscopy, you told me it probably took about an hour. That's about right. Even if it took an hour and a half, that's really pretty normal for a knee arthroscopy.
Mm-hmm.
But even I saw a little sticker shock there. But it reminded me of a very famous quote when I saw this bill. I just received the bill from my surgery. Now I know why those doctors were wearing masks. So, how did you choose United Healthcare for your insurance plan?
Really two things. One, I'm a small employer. I've got, 8 total employees and their family members, and very few carriers will offer insurance to small employers. So my selection ability was limited to begin with. And it was really, in my area, limited to either Blue Cross Blue Shield or United. United's premium was slightly less than Blue Cross Blue Shield's, and we chose on price. Their networks were, at the time I bought the policy, the same. The benefits were pretty much the same. So it was a price decision to choose United over Blue Cross.
And actually, like you said, everybody but the anesthesiologist was in network. So, I mean, you were able to find your doctor was in it, and the facility you wanted to go to was in it.
Well, at the time I bought the policy, the anesthesiologist was in network too.
Okay.
They were terminated by United in the middle of my policy.
Okay, so, and we'll talk about the reasons for that.
Yeah.
So you really have a good policy too. So just so the listeners know, because I mean, you were kind enough to show me your plan. You're one of these guys who buys the $250 deductible. I mean, that's usually the most expensive plan. But
yeah.
So you have what I would consider top of the line insurance for this carrier. I mean, I can't speak to them as a health insurance company. But when I looked at your EOB, your explanation of benefits, it raised a bunch of questions. So first question, and I imagine you had this question too. Why did you have two anesthesia providers?
Well, and again, partly I know from being in the industry, and partly they came and talked to me pre-surgery. The CRNA came and talked to me and said she would be my CRNA, would be monitoring me through the case, et cetera. And the anesthesiologist pre-surgery came in, introduced himself, said, I'm going to be the anesthesiologist. I'm covering 3 rooms today. I'll be monitoring your care. So I knew there were going to be 2 professionals involved in the care, and they both introduced themselves.
That substantially raised the cost of the anesthesia care from what I'm seeing here. So, based on your bill, am I okay? Is it okay if I say what the number was?
Sure, absolutely.
Okay, the anesthesia bill of $2,096 to me seemed extraordinarily high. I don't mean high; I mean extraordinarily high. Anesthesiologists charge on time and the type of procedure. We can put it that way. It's a combination of things. But based on your procedure, if it took an hour, we're talking about 8 or 10 units. Let's say a 10-unit case. We talk about units as that combination of startup time and the total time of the case. If you divide that by 10, that's $200 per unit for an anesthesia. That's numbers that are way, 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 way off the charts, higher than any place else. Were you surprised when you saw that number that they charge that much?
I wasn't surprised because I knew 2 things. One, when a provider group is contracted with a carrier, their charge level is somewhat irrelevant. It's really what you end up paying, what the carrier has negotiated as the payment level. So I see oftentimes things where charges are incredibly inflated, but nobody pays them. So what? So that was the first thing I knew. Now, these anesthesiologists aren't contracted with United, so the charge level does come into play. The other thing I knew is that this anesthesia group is one of the, I'll call them corporate anesthesia groups rather than a small independent group. They were part of a company called Mednax.
Oh, yes.
Yeah.
I know them, yeah.
And have since been sold to a company called North American Anesthesia. And these are groups that own and employ thousands of anesthesiologists across the country who get private equity money. I mean, it's more like a corporate practice of medicine. And I know that those entities, on average, have significantly higher bill charges than a sort of an independent local anesthesia group. So, seeing something that the bill charges were, 10 times what Medicare would pay. It didn't give me sticker shock because I realized I could see somebody else going, wait a minute, all they did was put me to sleep and they cost $2,000.
So the show today is on surprise billing, and when I saw that, I was surprised at that bill myself. And as you said, there are reasons that it's that high. Just frame it for the listener who actually may not be aware of what surprise billing is.
So the concept of surprise billing and the legislation that's being talked around it is just that. A patient who receives care, like I did, does everything right from their perspective. They choose a doctor that's in the network. They choose a facility that's in the network. They have this care. They think they've done everything right. And at the end of it, they get a bill that surprises them. Both they didn't understand they were going to get that bill, and they clearly didn't know that the bill was going to be significantly more expensive because that entity, whether it's an anesthesiologist, a radiologist, an emergency medicine physician, doesn't have a contract with their carrier. And they really had no way of knowing that or no way of avoiding this bill. So you get a surprise bill, and it's usually big. Mine was. And many times these bills can be, crushing for a patient who doesn't have the means to pay it or the understanding of how to deal with this. So that's what they call why they call them a surprise bill. I didn't know that I was going to get this bill, and I had no way of knowing it wasn't going to be covered in network.
I told you that it was a sticker shock when I saw how much the anesthesiologist charged, but I forgot to mention, when I saw how much United Healthcare paid, that was absurdly in the other direction, okay? And in fact, that didn't even measure up. Remember, we were talking about the Medicare fee schedule, which most doctors would consider inadequate. Mm-hmm. This was half of what a Medicare would pay for this, almost. I mean, maybe a little bit more than half of what Medicare would pay, but it was substantially lower than even Medicare would pay. So why weren't they at least obliged to pay a Medicare rate or Medicare plus 25% or 125% of Medicare?
So you're right. That was the one that caused me sticker shock. And that's because I do know the industry. And when I saw that United Healthcare had decided that for both of these professionals, the CRNA and the anesthesiologist, that the value of that was about $165. It just floored me. If I had been a new patient to my orthopod, which I wasn't, they would have paid him more for a new patient office visit than they paid for an hour's worth of anesthesia for both a doctor and a CRNA. That was ridiculous. Medicare would have paid him more for a new patient office visit. I also did the calculation and said, okay, here's what they're doing. They're applying what I think is the Medicare rate, which is ridiculously low and nobody could survive under for anesthesia. And then they're cutting the bill in half because they're saying, well, there were two people there, so I'm going to take each one of them and cut them in half, do a 50% reduction. Regardless of that, it's just a ridiculously low number. And that one caused me some sticker shock to go, holy cow, it means that the rest of the $2,000 minus the $165 is on me. I have to pay it. And in North Carolina, there's no requirement that they pay at a certain level. So they don't have to pay 125% of Medicare. They don't have to, they're left to really their own devices on what they think is fair. What people used to call UCR, or usual, customary, and reasonable, which is none of the three.
So on the one hand, the bill was really high. We'll talk about why so high. And then on the other hand, their reimbursement was way below Medicare, and Medicare is considered an inadequate rate to survive on. But we'll talk about that. You just mentioned something, and so about reasonable. So I looked up under the Affordable Care Act. And in the Affordable Care Act, it said when a patient receives emergency care or if they're out of network, the insurers are required to pay, quote unquote, reasonable rates to an out-of-network provider. So in the ACA, this is the federal law, did they define reasonable? How do we know what reasonable is in terms of what the insurer has to pay for an out-of-network provider?
It's interesting. A 2,000 plus page piece of legislation has some holes in it. And that's one of them. No, there was no federal definition of what is reasonable. And If there is another word in the English language that's more misunderstood or debated, reasonable is it. I mean, I don't know which one's worse. So, no, there's no definition of that in the federal law.
Yeah, and this is going to be the problem with the surprise billing as well. It's likely to not be reasonable on potentially both ends.
Mm-hmm.
So you and I understand this because we're in this profession and industry. But the average person looks at this thing and they say, it really raises these questions in their head that, like my plumber, he said he charges a certain hourly rate and he charges a certain amount for a certain job, et cetera, et cetera. But it's a funny thing about medicine. It's different physicians charge different amounts for their time and their energy and their procedures and everything else. How do different physicians establish these fee schedules? Because like this one's really high. Mine would be lower than that. Medicare is a different rate. The government tells us what those rates are going to be, and we have no choice. But how do the physicians establish their own fee schedules?
So there's a lot of factors that go into it, and some of them are incredibly logical when you think about it, and some of them don't appear to be that way. So, for example, we know that these large corporate practices, the Mednaxes of the world, the North American Anesthesia, they're rad partners in radiology. I mean, there's in every specialty they have them now. That part of what they do is charge significantly higher. They act like a for-profit company and they try to proceed, to achieve as much profit as possible. I don't see that in the independent groups. I don't see them set their charges on how do I maximize the profit. And instead, with the independent groups, what I end up seeing is them trying to build up how much revenue do I need to pay reasonable salaries so I can attract and retain good physicians. And those factors will think things like, what's the mix of patients at my hospital? If you're in a very poor rural part of North Carolina and your Medicaid and Medicare mix is significantly higher, well, then you probably have to have more money on your commercial business just to be able to staff that hospital. Some hospitals offer subsidies and say, well, I'll pay you a little extra to help you out. You're in a bad spot here. So you factor that into it. Other facilities have a much better mix of patients. They're in an affluent part of a suburb or a city, and you're not going to get a lot of Medicaid. And some of those groups then can charge less or contract for less. So all those factors go into it. But in most of the independent groups, they're really saying, I need to be able to offer a competitive salary package. What do I need to get there? And that's how they set those charges.
Medicare, Medicaid, they tell you what it's going to be.
Yeah.
In your situation, you're out of network, so it didn't really apply. But for the in-network doctors, like your orthopod, and in normal cases, if the anesthesiologist is in-network, they'd already have a negotiated fee. To your point, they could charge you $50,000, but the insurance company is only going to pay them $500 or whatever the normal fee is.
Yeah.
There's this third case. How does the fee schedule work if, God forbid, the patient has no health insurance? Do you make concessions for that? I mean, would you charge them the top dot like Mednax? Would they charge them the same rate for an uninsured patient, or would they say, oh, they have no health insurance, so we're gonna alter our rate? Because they do have different rates for different. Obviously, Medicare and Medicaid are different rates than their fee for service.
So the bill charge rate, their retail bill charge rate, the $2,000 you saw in the bill, that's going to be the same regardless of whether the patient is Medicare, Medicaid, Blue Cross, United, or no insurance. Okay, that's their standard bill charge rate. What happens is obviously Medicare and Medicaid don't pay that rate. They pay a rate they set. If you're contracted with an insurance company, they pay the rate they contracted with you for. And almost every physician, I mean, everyone I've ever talked to, has a financial policy for people who have no insurance, or for people like me who they were out of network. And they will offer a discount from that charge rate in order for prompt payment of the bill. So the anesthesia group, they're going to offer me a discount from the $2,000. They're not going to try to get the full $2,000 if I pay them. Now, many groups also have what they call a financial hardship policy, where if I were in dire straits financially, I could send them some information about the fact that I don't have much income, et cetera, and they will discount it even further. And this anesthesia group, I've already talked to them. They have a discounted rate for self-pay, which is what I am. Now, I told them at this point, let's hold off on that because I know that United Healthcare, the way they paid this, violated North Carolina state law. And so I'm appealing the claim to the Department of Insurance and to United and stating the general statute in North Carolina that they just violated. Nobody else other than somebody deep in the industry would know how to do that.
So tell me, what is it that they violated? And I mean, what does the statute say?
So there's a statute. It's North Carolina General Statute 58-3-20D. And it says, and this is for anybody fully insured. This is not under the Affordable Care Act. This is a state law. Services outside provider networks. So that's what I got. It says no insurer shall penalize an insured or subject an insured to an out-of-network benefit level offered under the insured's approved health benefit plan, including an insured receiving an extended or standard referral, unless contracted healthcare providers able to meet the health needs of the insured are reasonably available to the insured without an unreasonable delay. So basically what that says is they can't penalize me, the patient, which was what they've done by paying so low, paying less than they would pay if it was in network, unless I had an option to meet my healthcare needs with somebody contracted, and that option was available, reasonably available, without unreasonable delay. So part of what I did in my appeal was I pointed out to them there are no contracted anesthesiologists in my county, and that if I had chosen a contracted anesthesiologist, I would have had to travel to another county, and it would have delayed my surgery by probably 2 months, which I'm claiming is an unreasonable delay of care, causing me to continue to have pain and suffering that I shouldn't have to have. Now, I will win this appeal, and they'll have to pay the full bill, and they'll gladly do it just because it's like, somebody figured us out. But nobody else who's in this situation is going to know how to do this.
Right. One of the pillars of the Biden health plan, obviously, is stop surprise billing.
Mm-hmm.
Biden talks about people that who he's trying to protect, which it sounds reasonable. The people have no choice, kind of like yours or out-of-network providers. So let's say there was someone in your city that could do it, but you'd have to go to a different orthopod. You'd have to go get a different doctor, go to a hospital you didn't want to go to, or you didn't need to go to, or that wasn't your first choice. Is that really something that they're expecting you to do with elective surgeries in order to qualify for the law out of network?
So, yeah. So most of the Biden proposal and most of the federal laws, et cetera, would not have applied to my situation because it's an elective outpatient procedure at a freestanding ambulatory surgery center. Now, what would have applied, and this is not, I think, not necessarily a bad thing. Part of all these surprise billing laws would have said that I would have had to have been notified up front from the anesthesiologist, along with an estimate of charges. So the part of the law that I like and agree with is when I'm filing for this pre-scheduled surgery, I should have gotten a notice from the anesthesiologist saying, hey, I'm not in network. You're welcome to come here. It'll probably be about $2,000. I don't know how much your insurance company is going to pay. You'll owe the rest. And then once they've notified me, if I continue to move forward, it's on me. The Biden law wouldn't protect me from that because I'm choosing to do this. I'm making a conscious choice. And if I didn't want to have that happen, you're right. I would have had to find a new orthopod in a new area where everybody was in network.
Is there any law that states that people have to tell you in advance before you show up on game day? You know, you've taken a day off work. You've been planning a week off after your surgery and all this stuff. They can't spring it on you the day you show up because there's no way you can reschedule it. You've just taken a week off work.
Right. Right now at the state level, and this only applies to actually a small percentage of the people with insurance, there are like 28 states that have passed some version of surprise billing at a state level. North Carolina isn't one of them. And most of those laws have some sort of notification provision, and it has to be in advance.
Okay, you were just saying most states have it. California has passed a surprise billing law. It's called AB 72. Mm-hmm. What are the essentials of AB 72? What are like the bullet points of AB 72 to end surprise billing?
So the bullet points are It protects people from inpatient and emergency services. So if you're in an inpatient facility, even if it's an elective procedure or anything that happens in an emergency perspective, from being balance billed under a surprise bill. It also has some notification provisions about people have to be notified about certain things. And that protection basically says, regardless of this anesthesiologist or emergency medicine physician, regardless of their contract, if they are out of network with your carrier, but the facility is in network, the carrier can pay them the greater of what the carrier's sort of average payment rate would be for that specialty, and there's a problem there, or 125% of Medicare. So in my case, if I had had the surgery in California and had it at a hospital, and let's say the Medicare portion of that bill would have been $200 rather than $2,000, my carrier would have paid the anesthesiologist 125% of $200, and they would not have been able to balance bill me. They'd have to eat that and accept it and be good with it.
You said there's a problem with the average bill in the community. Why is that a problem? Like, so for example, you have United Healthcare. Let's say they're contracted with 10 anesthesia groups in California, and the average payment would be, instead of the $200 you said, would be $500. Why would it be a problem?
Because they control that average, and they can change it over time and will. So if I'm United Healthcare and I'm contracted with 10 anesthesia groups and my average payment is $500, not $200, well, that's probably because I've got a range of contracts. I may have a group where my average payment's $1,000 and another group where it's $200. So if I start terminating the higher contracted groups, then their contract doesn't count towards that average anymore, and my average moves down. So not only do I start paying less on that average, but the group I just terminated suddenly goes from being paid $1,000 under a contract to now they fall under the bill, and now I can pay them the $200. It's a win-win for the insurance company. I control my own destiny. I can drive that number down, and the process of driving that number down, I throw physicians out of my network and get to legally force them to accept significantly less money.
Yes, so in California, it's, everywhere you look, if you Google it, you'll find out that it says California's surprise billing law protects patients, but aggravates many doctors. That kind of language. Why does the surprise billing law in California aggravate doctors?
Well, it aggravates doctors because, let's remember, most of these practices have built up their revenue in what they need to attract and retain these physicians. And suddenly this law gets passed and allows an insurance carrier, big insurance carriers, all of them, to terminate them, pay them significantly less. So there's a massive revenue drop to the physician practice. Well, especially in these practices in radiology, anesthesia, and ER, there's no expense drop when that revenue drops. There's just a drop in the physician payment, basically. So every dollar that gets taken out of there gets taken out of a doctor's paycheck. And that's frustrating because they didn't have anything to do with it. They couldn't stop it. There's nothing they can do to fix it. It's a law. Now, the one good thing is the state laws only apply to a small part of the patients. If that same thing happens at a federal level, it's, a whole different world.
So the hospitals are also part of this. Are the hospitals more or less in the same boat as doctors, or not really?
Well, yes and no. I mean, the difference with the hospitals is there are very few hospitals. There are a couple, and they're notable. There's one in San Francisco that's gotten in a lot of hot water over this. But there are very few hospitals that don't contract with everybody. So they're in network. They have to be. So it really doesn't impact them as much as it does the physician groups.
So, but with the hospitals, why isn't the health insurance plan cancel their contract to force them to, negotiate much lower contract values?
For several reasons. One is the insurance companies know that they attract members, they attract employer groups by an attractive network. I mean, that's really what they sell. What the insurance companies sell is this collection of contracts with hospitals and doctors that they package together and put a bow on it, and that's what they sell to the employer groups. So if you're trying to sell your product and major hospital in a certain area isn't in your network, you have a hard time selling it because people will ask, okay, you take my area, they'll say, well, do you have Duke? Do you have UNC? Do you have Rex? Do you have Wake? Okay. Nobody says, and no disrespect to you or your profession, Frank, nobody says, hey, is Frank Sweeney in your network? Because you don't even know who the anesthesiologists are. I have a good friend of mine who said, I work in a specialty where there's no such thing as unnecessary anesthesia and nobody knows me, So they have to keep these hospitals in from a network perspective, but the hospital-based physicians, the radiologists, the ER doc, the anesthesiologist, they're not in the same boat.
So the question that arises here is, if Medicare, let's say California uses a benchmark rate of 125% of Medicare, and there's a surprise billing law that says if you do that average rate or 125% of Medicare, whichever is the higher number. So the lowest number you're going to get in the California surprise billing law would be 125% of Medicare.
Mm-hmm.
If California, the state, the legislators believe that's a benchmark rate, why can't payers just negotiate Medicare, 125% of Medicare rates with all of these hospital-based physicians, ER docs, anesthesiologists, pathologists, and radiologists?